makes high use of emergency ambulance services, and how are services responding to meet the needs of these patients? This is a panel session at HSI UK Conference 2020. My name is Helen Snooks. I'm the Chief Investigator of the STRETCH study, which has been funded by the National Institute for Health Research, Health Services and Delivery Research Programme on this topic. So what can you expect during this panel session? Firstly, I'll give some background and context to describe the current situation and the issues. I would introduce each panel member, who will then make a short presentation. I will then summarise key messages from those presentations, and as a panel, we will respond to submitted questions and discuss the implications of these questions. I will then sum up, and I will thank all the panel members, technical staff and viewers. As you can imagine, this is something new to us. We hope that you'll bear with us. We haven't done anything like this before, but we're doing our best. So the background and context to the problem. Well, we all know that although most people in their lives make very few calls to the emergency ambulance service or visits to the emergency department, at any one time, there is very heavy use of these services by a small minority of people, perhaps for a temporary period during a high level of crisis in their own lives, or perhaps for a more prolonged period. Half of people that are contacting the 999 or emergency department services frequently are doing so for a mental health problem. Other reasons for calling frequently include falls, addiction, and social isolation. We know this from the research literature. Ambulance services and emergency departments are, of course, under sustained high pressure, and multiple presentations for complex problems can cause operational difficulties, so that emergency departments and ambulance services struggle to meet their performance standards in terms of response times for the 4-hour target in the emergency department. Clinically, this is a very high-risk group. And the fact that people are making repeated calls or visits is very frustrating for them because their needs are obviously not being met. And for service providers, and for the ambulance service, paramedics and technicians, and for emergency department clinicians as well. Some areas have taken a new approach to trying to manage people who call frequently or better. And this is a multidisciplinary case management approach, which is across services and across sectors, where people from social services, from the emergency department, from primary care, from the police, from the ambulance service, and from the third sector come together to discuss the issues that people are presenting with in a holistic way in order to come up with a care plan to try to achieve two things: to address the needs of the caller and also to reduce the presentations through the emergency services. Our panel members today are Jason Scott, who's a senior lecturer at Northumbria University and former chair of the National Ambulance Service Frequent Callers Network; Chris Richmond, NHS England's Right Care Innovation and Strategy Lead, formerly emergency care practitioner team leader at Yorkshire Ambulance Service; Penny Gripper, who is a service user and has experience of accessing emergency care. She brings a unique perspective to this area. Ashra is a researcher who facilitates the involvement of patients and the public in research, particularly in this area, and works in the Swansea University Medical School. Jonathan Hammond-Williams is a clinical development officer and frequent caller lead for South West Ambulance Service NHS Trust. So during the presentations and in our discussions afterwards, we will be addressing questions which include the following. What are the implications of current variation in care for patients and for the NHS? How does the use of language and media attention affect care provided? What evidence do we need in order to inform policy and practice? And how can we ensure that research evidence has an impact in this area of care?
Hello everyone and welcome to this session on frequent use of ambulance services. My name is Jason Scott. I'm a senior lecturer in public health at Nottingham University and I'm the academic lead for the Frequent Caller National Network. What I'd like to talk about today in this presentation is to give a little bit of background to frequent use of ambulance services, and then I want to move on to talk about what sort of impact the COVID-19 pandemic is having on frequent use and what sort of challenges the ambulance services are experiencing. Who it is that frequently calls ambulance services, the first and most important point to make is that these patients are, for the most part, not vexatious callers. They're not doing so to be a nuisance. These are people who have unmet, multiple and complex physical health, mental health, and or social care needs. They're certainly not a heterogeneous population, and this is certainly not an issue that exists just in the UK either. There's an increasing amount of evidence coming out from many different countries, for instance, the US, Canada, Netherlands, Singapore, Thailand, Denmark, Australia, Spain, and many other countries as well. So in England, each ambulance service has an average of around 600 to 900 frequent callers a month. Of course, there's some variation around that, of which around about 100 a month are newly identified. And what we mean by a frequent caller here is somebody who calls the ambulance service 5 or more times within 1 month, or alternatively 12 or more times within 3 months. And those all have to be unique incidents. So it can't be somebody who's called up once in an emergency and then called up subsequently another 5 times in the next hour after my family. These are all unique incidents. In terms of what drives this behaviour, so I've already said it's related to these unmet health and social care needs. There's an excellent piece of research conducted by Mahmood et al. In North America years back. And I really like this model because it really underpins what it is that sort of motivates people or drives people into this behaviour. So for here, for instance, you can see that starting at the top left, and it might be an opportunity to pause the video as well if you want to have a good look at this. You may have people who have chronic diseases, COPD, asthma, where there's been some sort of either exacerbation of the illness or they're struggling to manage it in the community themselves, or for the support they've got in place. Might be people with mental health problems, mobility problems, might be people socially isolated, alternatively lonely, alternatively people who are falling and the lack of social support around them to be able to help them. So all of these different factors contribute to, and we see the exact same within the UK as well. Now, in terms of the pandemic, I think this is really important as trying to understand this behaviour, because we know we've been living through this. We've had the societal lockdown, which is combined with social and physical distancing. Now, I think it's quite fair to hypothesise that this really does have the potential to exacerbate frequent use. But what we've been doing as part of the national network is trying to get a bit of an understanding of what is actually happening. And we know from the group, speaking with a representative of every single ambulance service in the UK, that the services are seeing new frequent callers due to health anxieties, which are either caused by or exacerbated by the pandemic. Generally speaking, there's been an increase in the total number of frequent callers, but we don't quite have a hard date on that as of yet. Clinical case management, which is the sort of standard approach to managing frequent callers, is becoming more difficult. Now, this is a multidisciplinary, multi-agency way of working, which includes the likes of the community and voluntary sector. And so because of the lockdown and because of staff who are self-isolating, it's becoming more difficult to deliver that case management. Services have also seen decreased face-to-face contact with frequent callers, which is resulting in less person-centered care. It's a lot more difficult to identify someone's social situation without being able to meet them in person. Now, to an extent, services are trying to adapt the increasingly use of tele-video conferencing facilities, which to an extent has mitigated against some of these, particularly in delivering clinical case management. There's one example, one service who found that this has actually improved collaboration with primary care because it's less of a demand on their time. They'll have to travel somewhere for face-to-face meeting. But on the other hand, it does have the potential to exacerbate inequalities where treatment callers are amongst some of the most vulnerable people who can't access or struggling to access appropriate services. And therefore, there's potential that using digital technology to connect with patients is going to limit the access that some patients may have to the ambulance in terms of clinical case management. Of course, 999 is always an option. There. If you do have any questions, then feel free to get in touch. I'll be more than happy to answer. I'm always happy to talk about this topic as well. But thank you very much for listening.
Hello, welcome to the HIU Youth Programme delivered by NHS Right Care. Scoured by NHS Right. My name's Chris Richmond, and I've been working on delivering this nationally and expanding this nationally. For 20 years before joining Right Care, I was a frontline paramedic, so I've worked with lots of people who we're all discussing and familiar with. So HIU is a core programme that looks to demedicalise, decriminalise and humanise people, so it puts people back in the middle, helps them flourish and have value in society again. It works by identifying the top 50 individuals most frequently attend A&E. And then it's a coaching process. The top 50 doesn't sound many, but you work with people to ensure that they have a link and you get to the bottom of their problems. And sometimes interventions can be very, very quick, and a number of short interventions, some take a little longer. So it can range from sort of 2 or 3 interventions up to sometimes working intensively sort of up to 9 months with people. It has impacts on the health system. So there's tens of thousands of people who attend A&E more than 20 times a year. Those are examples of reductions in activity that we've experienced across a whole range of the services that are all provided flat. This is the real reason that we have the high intensity use program. So we've had quite a journey in the sense that we managed to scale into 120 CCGs, and despite COVID-19, which of course has changed how we're doing this and still continuing to grow, working with the systems has helped support people through COVID when people are very, very health anxious, but actually it's helped maintain some services. And actually, some new ones have actually rolled out while we've been doing this. Some in particular being aimed at male suicide, but it's been commissioned mainly to aim at people with male suicide, risk male suicide. So what we've learned, you have to pick the right people to do this, and these are what we say is the lead really needs to have really good emotional intelligence. You need to understand people, you need to be a good communicator, you need to be articulate. In addition to that, you need to be able to do some of the other stuff, the outcome measures, managing a digital platform, managing that with supervision. But on the whole, the right person can do this, and they can all walks of life. Can be some clinicians, some non-clinicians, football coaches. One HIU leads was a former owner of a lap dancing club. Obviously, got very good interpersonal skills, able to relate to people. We like to do things linked up, so we have lots of learning sets throughout who we can do this with. We encourage people to share ideas and best practice. So lots of this is done over a WhatsApp group, but we also now have a group on Microsoft where we can do this as well. This allows us to share ideas and people to confidentially share information about clients when they've got a problem and how to approach things. It also helps build capacity and resilience within the system, and it's a really good way to share and make it sustainable. So we're continuing to scale. So we're in 120 CCGs, having a massive impact. So COVID-19 has caused us to do things slightly differently. We want to make HIU business as usual now, working in with personalised care and personal health budgets. We can actually do that. So we think we're having a positive impact, and we can demonstrate that over time. We also want to do more evaluation around this. Identify the areas that we work with. We have an activity tool which shows average cost savings topic for HIU. We break it down to share it with people to understand what is the impact on the system, to understand whether it's worthwhile commissioning a HIU thing. What is the future of HIU? The future of HIU is NHS isn't going away. We've had people as high intensity users of services since the NHS started. What we can do is we can work in different ways. And actually work with all of the other types of schemes to ensure a holistic approach to these people. This triangle suggests how we could work with people with the core model, and we can link it. So what we look at doing is delivering a seamless, holistic approach to care where they don't know people are being referred to another service. It's just a continuum of care. This will allow continuity to allow these people to feel valued, not to feel like they're being handed off, to help work on those health anxieties, to help them make wanted. It's almost like Nanny McPhee in the sense of when you want me, but do not need me, I'll be there. When you need me, but do not want me, I won't be. Thank you very much for listening, and I hope you found this informative.
I felt rather daunted by the responsibility of making this presentation on behalf of a group that regularly has such an undeserved bad press. I stared at a blank page for days, not knowing where to start. I used to fall into the category of high-intensity user of emergency services, a term which immediately invites assumption about whether those contacts were necessary or not. Press releases by paramedics who were clearly angry about frequent use, which by definition was deemed to be unnecessary, really hurt. However, messing about with the language to make it more compassionate and understanding, whilst a helpful start, is not enough to change the attitudes that make people feel unwelcome when in need of urgent care. Just because they need urgent care a lot does not make them bad people. This group has a higher risk of dying than people who aren't high users of emergency services. The message that I felt was given to me by the attitudes I met were that the emergency services were not there for people like me. Wounds were not worthy if self-inflicted, and danger of loss of life does not count if it is self-inflicted. Ergo, my life and the lives of people like me do not matter. There is a real issue around the lack of parity between physical and mental health, combined as it is with significant gaps in services. In many parts of the UK, there is no out-of-hours emergency service for mental health. And there is a yawning void between services in primary and secondary care, into which up to 70% of service users fall. Where do you go when the primary or secondary services tell you you have to attend A&E? Where you will find crowded, busy public waiting areas which will increase your distress, and where you know you will probably not be made welcome, at least until the duty psychiatrist shows up. One time, I waited until the wee small hours of the night to attend, to avoid crowds. I had a skin thickness wound on my arm, which butterfly plasters were not keeping together. I was made to wait over an hour, even though the facility was empty. And when finally seen, the doctor refused to stitch the wound because it was self-inflicted. Fortunately, a more senior member of staff agreed to do so. My experience also included similar responses from voluntary sector organisations set up to provide support for people in crisis. Call Helpline asked me not to contact them anymore, as my needs were too great for them. And even Samaritan's email support told me I should stop contacting them. So for me, and as far as I know for others too, being turned away from services when I had long-term high needs is not unique to the statutory sector, which makes it all the worse when you are turned away or resented there too. From my perspective, there is something about having a chronic, intermittently life-threatening condition that has no easy solutions. I saw my stepfather, who had Huntington's disease, also a frequent user, in a similar position, in and out of casualty, sometimes more because his care workers wanted the reassurance that they had taken appropriate action than because his condition was needing urgent care. It was not his fault, but he was still judged. I have not been fortunate enough to have experienced any of the managed care options. As far as I can see, though, these cannot pick up all the people who meet the frequent caller definition, and only skim off the most frequent callers. What concerns me about these services is that they only support people for a maximum of 3 years, when chronic conditions can last considerably longer than this. And after that, people can get punitive responses and even end up in prison. I am very fortunate to have now been finally discharged from mental health services due to a secure recovery. But it took over 17 years to get to this. 3 years is a very short time in mental health. However, the approach of trying to meet the individual's needs so they don't get to the point of needing emergency care is a good one. It plugs the gaps in services, and for most who are engaged, it is enough. If researching the evidence base is going to mean wider take-up of managed care, it is a good thing, especially if the work maintains a compassionate approach and respectful language, taking great care not to assume frequent calls or attendances are unnecessary. Thank you.
Hello everybody, my name is Jonathan Hammond-Williams and I am the frequent caller lead of South Western Ambulance Service. I'm also the joint vice chair of the Frequent Caller National Network. Frequent users of ambulance services are a difficult cohort for 999 services to address. It is often not within the gift of the ambulance service to accurately address the root cause of the problem identified by the person calling frequently, and often reasons given for the 999 call are either a symptom of a wider problem, or users are a way of eliciting a response for an acute problem, when the root cause of that problem may be more difficult to address in the emergency setting. By that I mean, there may be other causes why they feel the need that they need a response. This may be examples such as social isolation and loneliness, or a lack of support within the community, which may increase anxieties about known chronic problems. However, when we receive these 999 calls, we are still commissioned to provide a response. This may be in the way of sending an ambulance to the scene, leading to either a see and convey outcome where the patient is transported to hospital or other healthcare facility, or a see and treat outcome where the assessment at scene shows there is no need for a conveyance to hospital or other healthcare facility, and the patient is left at scene, possibly with some referral put in place to provide ongoing support following the departure of the ambulance route. Analysis of the data shows that frequent callers to ambulance services are not the same as frequent attendants to hospital emergency departments. Frequent callers have high volumes of hear and treat and see and treat outcomes compared with the rest of the 999 patient population. Use of emergency resources in this way shows that many emergency ambulance resources are being used by high-intensity users. Across the UK, between 5 to 10% of all ambulance activity can be attributed to people that meet the national definition of a frequent caller. That's somebody who is over 18 years old, that's contact the ambulance service 5 times a month relating to individual episodes of care, or alternatively 12 times over 3 consecutive months relating to individual episodes of care from a private address. In the southwest of England, SWAS receive approximately 950,000 incidents per year. So that means 95,000 of these can be attributed to those meeting the national definition. This high level of use of reduces the availability of emergency ambulances to the rest of the community, which may in some cases lead to a delay in response to life-threatening cases, as our crews are not available to be sent to those individuals. Alternatives to 999 are often in a better position to provide the level of support this cohort needs, but reducing the number of times 999 is needed. Data can be difficult to collect due to the command and control system in place within our control rooms. Currently, this is often address-based, meaning pneumatic presentations can be missed, which may include those people that are homeless or have to move frequently due to their social situation. This makes things difficult to track or to provide information from our clinical hub, where our control room is, about a pneumatic presentation where somebody presents away from their home, and difficult to identify those that are not calling from their home address. This means our response is not supported by care plans and consistent approaches to deliver the right care in line with agreements made by multidisciplinary teams. Common causes for frequent use of ambulance services include mental illness or mental health problems such as anxiety and personality disorders. This cohort of people need to feel cared for, and they may have genuine anxieties related to known chronic conditions. It is not a simple case of needing attention. Community support for these individuals is vital. During the coronavirus and COVID-19 pandemic, we've seen a different cohort of people come in. Those individuals that we have known have been high volume use of 999 for a long time, for whom we have clear plans for and knowledge of their level of clinical need and their level of clinical risk. Those people have almost stopped calling, at least in the southwest of England, and I know that that's also the case across the country. Whereas SWAST alone saw 1,000 new people present to us and meet the national definition of a frequent caller. An analysis of the data behind this showed that this was often due to a breakdown of social support. This may be family members coming in to support them, a lack of ability to see their community mental health being face to face due to difficulties to protect staff to go out into the community during the pandemic. Regular contact and appropriate support and reassurance can help these individuals. Success stories come in many guises. The NHS Right Care programme that we have in Cornwall saw a person that had been in ITU 5 times the previous year and went on to call 999 30 times a month consistently every month due to a need to have reassurance that her asthma was not out of control. She would cause for shortness of breath, often. However, retrospective reviews of the assessments by various ambulance groups showed that the majority of her presentation had no physical health need. Actually, this was based very much in her anxieties of her previous need to go to hospital. Support from the NHS Right Care programme supported her in her community, and saw the patient stop meeting the national definition of a frequent caller, and now she engages in the community and has a much more full life. In Devon, we have also engaged with the Serenity Integrated Monitoring Model, also known as the High Intensity Network. This has seen an improvement in engagement with services too, seeing more community support in the use of mental health services, police engagement, and where necessary, court intervention. Common fears surrounding this programme include concerns about this model using punitive action against a group of vulnerable individuals that need care and support. The reality is that each person is different, and for some the right care approach works, and for others they need a different approach. We've seen success stories from the SIM model too. The model looks to support people and bring them in line with the rest of the community to ensure that they are accountable for behaviour, whilst encouraging them to engage with consistent approaches where standard operating procedures across mental health, police and ambulance are taken up, and agreed care plans where the person engages in the service and takes ownership of their own care and support so that they can be in line with that care and be consistent in their way to move forward more positively. Generally, in relation to ambulance services, we need support. Commonly, frequent caller teams across the country are small despite the large workload to review and collaborate with thousands of patients per year. Through good collaboration and engagement with others in primary and secondary care, as well as in acute trusts, as well as through set-up multi-agency groups, we can see that good progress is being made to ensure the right care is provided for this vulnerable and complex group that need input that are commonly accessing emergency care where more support earlier in their journey may prevent them from feeling that they need it. I'm going to finish it there, but if you have any questions, please contact me. My name is Jonathan Hammond Williams, and we will look to answer any questions you may have. Thank you.
So thank you very much to our 4 presenters. We've heard from the perspectives of people involved with from a wide range of perspectives, including people involved in researching in this area, in policy and commissioning, a service user, and from the perspective of a service provider. We've heard about reasons and patterns for high use of emergency ambulance services, about current policy and care initiatives. We've heard about personal experience and the impact of bad press. We've also heard about the importance of underlying problems and the inability of emergency care providers to always address root causes. Finally, we've heard about how important it is during this COVID-19 pandemic and lockdown that we understand some but not all of the effects on the needs, of the patterns and needs of people who call frequently, and that there are new people calling, and people that were calling frequently before are perhaps not doing it so patterns are changing. We're now going to move to the panel discussion section of this session. I welcome all the panelists back. And we're going to address some questions that were previously submitted by members of the team that I work with in Swansea University. So the first question that we want to discuss is, how can we change negative stereotypes towards high-intensity callers of the emergency services? And Penny is going to start us off with her view on this question.
Thanks, Helen. Dealing with changing attitudes and stigma is a very difficult and complex issue. So it needs to be approached on a number of different levels. More positive messages to the press would certainly help, as would training and awareness for staff with a more values-based way of working and strong supervision linked to that. We need to hear more stories that personalise the experience and make it more relatable.
Thank you, Penny. Did any of the other panel members like to add to that?
I think from an ambulance perspective, I'm sorry, I should put my hand up. But,
Go ahead, Jonathan.
I think from an ambulance service perspective, I think Penny's absolutely put some really good points forward. I think clinical supervision, so that actually there are discussions had within service providers about sort of what works well, what doesn't work well, and how we can change, because a stigmatic approach does not work for this cohort as well. It only makes things worse for not only the individual but the provider themselves and the whole situation. I think patient stories are very, very strong, and I believe that actually if we can incorporate those into guidance, then it will become much more part of the DNA of a service provider of how they approach high intensity service users. Thanks,
Jonathan. And Jason, did you want to add to that?
Yes, I was just going to say that Penny made an excellent point during her presentation that it's about delivering compassionate care. And I think that's incredibly important to sort of highlight and sort of agree with. I also think as well, another part is that certainly speaking to some paramedics in the past, frequent use can often be a source of frustration, but it's not frustration with the service users, it's frustration with the system that's leading to that behaviour. So I think raising awareness amongst paramedics, amongst frontline staff, but actually things are being done, and ultimately trying to make the system better for the service users is a way to do so.
Thank you very much. Ashra?
I just wanted to ask, I've come across the term compassion fatigue within, say, the ambulance service or ED staff. Is there any training in place to sort of address that, and how do we support staff to sort of respond in a more positive manner when they see the same patient come in week after week?
Chris?
So I think, yeah, you're entirely right, Asher. I think compassion fatigue affects different people in different ways at different times. And I think it all depends on what happens at home sometimes, what's happened to your previous interactions with that person. It's a very, very complex thing. It's going to be really hard to support people because it affects everybody differently. I think what is important is the coaching, mentoring and support that staff need to do this. And we've created a perfect system to get the results that we get, in the sense that we rush around, we don't actually get closure a lot of the time. So I think compassion fatigue is a massive thing. It affected a lot of my colleagues. It affected me at times, but I think it is something which affects different people at different times in different ways. And I think that is really important to note.
Thanks, Chris. Jonathan, did you want to add to that?
Yeah, just to add to something that Chris said, really, it's about the individual. There's lots of things going on in those persons' lives who provide the service. Clinicians are human beings too, and it's about the mental health and mental well-being support that those people receive from their employer, so as to reduce the risk of any compassion fatigue.
Thank you. Okay, we're going to move on to question 2. And this question is, what do you think works well in the current response to and care of high intensity callers? And Jonathan is going to start us off on this one.
Yes, hello. I think there's various different things that work. There's not one big solution, but essentially it's all about collaboration. So people talk about location. For this, I'd like to say collaboration. Multi-agency meetings, multidisciplinary team meetings, patient-centred care plans are absolutely what works here. It needs the patient's engagement with it often. However, that's not always necessarily easy to obtain when that particular individual has been through so many various different things within their life. Often, various different high-intensity users may have experienced something way before they became any sort of high-intensity service user that we could not understand. And until they're ready to engage, it's difficult to get them involved in making up that care plan. So sometimes we do have to work sort of with each other without the patient to ensure that we're providing that care, the right care in the right place. But wherever possible, it's about patient engagement and collaboration together to ensure that responses from various different healthcare providers are consistent across the NHS.
Thanks, Jonathan. Would anyone like to add to that?
Yeah, so just to support what Jonathan said, actually, some of the research that I read around Cumbria shows that some people have had trauma early in life, and by trauma it could be anything. It could be the breakup of a marriage, which didn't affect them at the time or in childhood, and that has a significant impact on them in their later lives that we don't recognise, because that trauma was such a long time ago and it's been packaged. We're very good at packaging things, and there are things when people become socially isolated where these things unpackage, and until you get to the root of that problem, you can never solve this. So having early intervention, so the early intervention for IAPT and things now will certainly help prevent some of this. It's not going to eradicate some of the issues around trauma in early life, but actually having access to talking therapies and more wide access and joined up mental health services can certainly help in some respects, but it's not the golden pill to save everything.
Did you want to add to that, Penny?
No, thank you.
Okay, anybody else, or should we move on to question 3? Question 3, please, Neil. How is cross-sector multidisciplinary case management funded, and is it sustainable? And Chris is going to start us off on this one.
So some of the work we've done with Right Care is we've successfully implemented a lot of pilots around this. So this is where we've got this off the ground by the simple reason that we've shown activity reductions that can potentially release money for the system to reinvest in the care of people. And what we show is that actually a modest reduction in activity can actually fund these services, but have a big impact on the whole system. Unfortunately, where this doesn't work is that we are only measuring the aspects across health. There are a lot wider aspects across the education sector, housing, and other areas we don't actually measure the benefits. Actually, if we were to pool this, it would give us a sustainable funding route by which to have services which cover that continuum of care that I previously mentioned, because it's a multidisciplinary, multi-partnership working is what we need here. There's no one person that can solve these people's problems and access to this, ensuring that we release the benefits in the system so we can support the people who can have better outcomes because of releasing the benefits in the system. So there is no big pot of money. So we, in the NHS, we have to move money around because there is no money. But recognising that the modest reduction in activity that some of these people can have, because some of these people are very high users, can have a real impact. But the money is only part of it. It's a benefit to the people that is the real benefit to everybody.
Thank you, Chris. Does anybody want to add to that? Jason?
Yeah, I think an important point to make here is that we still don't really understand the cost effectiveness of various different types of interventions for frequent callers. So in terms of the question of how is it funded, then it may well be possible, and we don't know yet, but it may well be possible that actually it's funded through savings that have obtained by the interventions themselves.
Yeah. Thank you.
Jonathan.
Yes, Jonathan.
So, as you may know, ambulance services across the country are regional, so they will more often than not cover various different clinical commissioning groups, and each clinical commissioning group will have its own pot of money for its own particular area. So that means that when an ambulance service approaches them to get money, they will want to ring fence whatever they commission to that specific area, which doesn't necessarily mean that we're able to provide one whole service across an entire area. So that's why ambulance services link in with various different sort of high-level programs, such as NHS Right Care, the Serenity Integrated Monitoring System, and look to sort of have more local engagement across a wider patch. But when various different services have put in business cases about trying to get larger frequent caller teams to increase the level of collaboration they can do, this has been patchy in where that has been successful, because although we can actively show that we can reduce activity and we can help patients, often from an ambulance service perspective, that's not necessarily cash releasing.
Yeah.
So yeah, as Chris has said, it's about realising the benefits within the system when we free up resources to make a more safe and effective service across the patch, really. And that's where commissioners will see their gain across the system. But in relation to funding, there's no one giant pot that helps everyone because of the way that the CCGs are split.
Thank you. Interestingly, when we were planning research in this area, we carried out a survey of ambulance services across the UK to find out current practice, and discovered a lot of variation in care, which for researchers is an opportunity, because we are then able to compare areas with new initiatives with areas with more standard care. So it did allow us to plan a research study to evaluate costs and effects of case management, for instance. But in terms of standardising care, it's not helpful. But it does help us to collect some research evidence at this point. Can I move on to question 4? So this is a very current question. What effect has the COVID-19 pandemic had on the response to high-intensity callers? And Jason is going to start this one.
Yeah, so what we've seen across the entire UK is that, first of all, there's been two different impacts. One on the impact that it's had on patients and service users, and then the impact that's had on the services itself. So for patients or service users, what we're seeing is that, generally speaking, you can divide the cohort into 3 different groups. There are the current frequent callers, whose behaviour hasn't changed or possibly even become more entrenched. There's current frequent callers who have stopped calling entirely. They've disappeared off the radar, and we don't really understand why as yet. And thirdly, and perhaps possibly most importantly, are the new callers, new frequent callers, who are doing so because they've got health anxieties, a little bit like discussed in presentations, health anxieties, and there's also reduced access to community voluntary sector services. And ultimately, there's been a breakdown in their social support mechanisms, whether that's health or social care based or whether it's more friends and family based. And that's all contributing to it. In terms of the response from services, as you said before, Helen, around regional or a great deal of variation in practice, again, we're seeing the same thing. At one end of the scale, we're seeing that frequent caller teams have essentially been moved away from that work entirely and have been placed on the front line instead. And so therefore they can't actually do anything with the frequent callers, possibly at a time where they need to do things more. Alternatively, there has been a lot of work going into other services where there's been an increase in teleconferencing and other alternative strategies to try and engage with the multidisciplinary team working.
Thank you, Jason. Chris?
I think, yeah, to pick on what Jason said, and we certainly found this in the Right Care approach, the teams were at risk of being moved away from their day jobs because a lot of the interventions from our approach were one-to-one humanistic interventions, and it was really hard to reskill the teams, if you like, to do the same types of interventions via video chat or via telephones, because we're trying to change those behaviours and we don't want people interacting that way. But what we found is that in a lot of areas, they're actually being people responding very, very well to this. So a lot of the high intensity users that they're working with, because they've got the established relationships, are responding very well to the change in delivery and they still feel supported. But what that's doing as well, because they can do their interactions a lot quicker because they've not got any travelling time, it's actually freeing up time to support other aspects of service delivery and care delivery elsewhere. We're actually sometimes potentially picking up more patients and doing those quick interventions with the people who are anxious because of COVID. And it's quite interesting to see how people are responding flexibly to this to meet the pressing demand.
Mm.
Thank you. Jonathan?
Yeah, just one more point from me, really. Across the country, as both Chris and Jason have said, various different teams have been sort of put back into operations to help with the response to COVID. However, in the southwest of England, what we have seen is actually due to the number of staff that need to shield and therefore work from home, and the support we've been given to enable home working, we've actually seen an increase in the number of people who are working within the frequent caller team, which has helped us to review the number of people that are new to us as well. So it's a change in work dynamic as well as sort of the change in the population that we're seeing that meet the national definition.
That's very interesting. Thank you. Okay. Ashra, yes.
Can I just ask one question quickly? A number of people who call 999 service or attend DD often are coming from a background of living in precarious housing situation, are often homeless. Do you think that maybe this population the number of calls coming from this population has decreased because of the way government has policy has encouraged local authorities to house these people, and actually maybe then they probably are able to then access further care that is meeting their needs?
Chris?
I think it's a really good point, Ashra. I think it's going to be very, very difficult for us to measure it in this current time. And I think this is a really good piece of work for researchers to do after this, because as we've said, understanding the impact through the system of changes is really, really hard to measure in this cohort. I think it is going to have an impact. Is it going to have an impact on the 999 calls or the activity at ED? It's hard to say, because actually a lot of people are frightened of going to the ED or asking for emergency for the simple fact that they're worried about getting COVID. So they're more worried about getting COVID than their other underlying health conditions. It's really, really hard to say. I think it's a really interesting piece of research going forward to understand why, or if there was a change in behaviour at this time, and what were the contributory factors? Was it a change in policy over housing, or was it health anxiety or other related issues?
Yeah, thank you.
Thank you. I think we're going to move to our last question now. Oh, sorry, it's the penultimate question. Question 5. What role can families, the community and non-statutory services play in addressing the needs of high-intensity callers?
And I've got down that Jonathan was going to have a go on this first.
Yeah, hi. So I think the simple answer is they can play a huge role. They're absolutely pivotal to how any particular individual will get by from day to day. So many people that meet the national definition of a frequent caller have their root cause being social isolation. It's not so many of us as human beings are surround ourselves naturally from an early stage with family and friends, and if you reach a certain time in your life through various different reasons that actually those people aren't around you, then of course you're going to reach out in some way. I can give an example of what I've seen in one of our areas in the southwest, which I'm really looking forward to seeing the results on. We're just about to sort of start it, and then we're looking to do a short evaluation within the next few months. And that's with the Community Council for Somerset. They have community agents and village agents. And these aren't anything like James Bond, but they are people who absolutely go into people's communities and help them with day-to-day tasks. Some are volunteers, and some are paid employees of the Community Council for Somerset. They will support people with their day-to-day activities. So they'll go out and get shopping for them. They'll pop round for a cup of tea and have a chat to them. They will try anything they can to reduce social isolation. They will work with that person to see what they need. So if they're saying, look, I call help because I just need help getting up off the floor, then actually they will make sure that somebody pops around regularly throughout the day, so that if they are on the floor, then they'll see if they can help them up. And it's just really simple local solutions for local people in local communities. And we're really looking forward to seeing what can be learned from that experience. But if we go back to how COVID has changed people's sort of calling habits, we have had various different people who normally are supported extraordinarily well within the community, and when those support networks are taken away because of lockdown, or sort of somebody's unable to get back to the UK because they're stuck in a foreign country and there's no flights home, actually they have turned to 999 because somebody who would normally look after them isn't there. And this could be a family member or a domiciliary care provider. So the role that families, friends and the community plays is humongous in this particular cohort of people.
Thanks, Jonathan. Jason, did you want to add to that?
Yes, so one thing that we haven't really discussed much today, due to time limitations, is also the role of NHS 111, who will have their own cohort of frequent callers too, who may be similar, same, or completely different from 999. So the piece of research I've been involved in recently has been looking at potential referral pathways for social prescribing within 111. And again, so around frequent callers is one potential cohort. But there's real potential value there, where we need to look at whether it's NHS pathways or AMPDS as a sort of dispatch system, and to see exactly where in the pathway we could potentially socially prescribe. And it may actually get to the point where not everybody needs to go through to a frequent caller team to then be clinically case managed. We might be able to do that much earlier within the patient's pathway. So that's also another potential.
Thank you. And Penny?
I think there is a risk in trying to delegate too much to the third sector of the community. And I think it's got to be recognised that sometimes the carer is part of the problem and is not going to be a part of the solution. I found in my own situation that I reached out to everybody and anybody, but they couldn't compensate for the fact that I wasn't getting access to the right statutory sector care. So I think it's really important not to make sure we don't overinvest in the third sector, and in doing so underinvest in statutory services.
Yes, Chris.
Just one thing for myself is that we've worked really closely with the British Red Cross on this, and some of the knowledge that they've brought to this and the ability to mobilise some of their volunteers is been key to some of the successful delivery of what we're doing. But again, the success is the sum of the parts. It's not the intervention of one HIU individual. It's what can that person do? What community anchors can you use? What what hooks are in that community to help provide some of that support, either statutory or non-statutory. Some of it will have to be statutory. There's lots of really good non-statutory support out there which can help people get back on their feet, help them, have that sense of purpose again, which is really missing in some cases. Not all cases, admittedly, but in some cases. I think that's really important. So if you can act as a volunteer, they can start to get back into work. Because they start to get back into that workplace, they start to feel valued again. And you can start to get those subtle changes that people may need to do. And I think so it's the sum of the parts rather than any one intervention.
Mm.
Thank you. Yes, Jonathan.
So yes, just to follow on to that, I think it's important to realise that sort of statutory services are absolutely there, and they should be used to address things that they are commissioned to address. Penny's example, if she needed mental health care, then it's up to the mental health services to provide that. However, friends, family, community, third sector, community volunteers can always help as well as those statutory services. They're not a replacement for it. It's just extra support whilst they're waiting for their next appointments and things like that. A more day-to-day thing.
Thank you. I think it's really important to remember as well, isn't it, that this is not one type of person or patient or condition, that it's a very varied group and that different things are going to work for different people. Yeah. Okay, we're going to move on to this is the last question, question 6. If you could put it up, please, Neil. So this is a question about, leading on nicely, which patient group benefits most from current cross-sector multidisciplinary approaches to care? And Chris was going to start us on this one.
Well, I'm going to be quite contentious on this point in the sense that there's, as you just said, and as Jason's pointed out in his presentation, there is no one group of people. This is not a homogenous group. This is a group of several million individuals. But actually, what we're finding is, and I'm going to generalise a lot here from the data that we've collected, is that people between 18 and 65 are at greater risk, believe it or not, of being a high intensity user. These are people who can normally access health services, don't have any problems accessing health services usually. And some of this is down to, divorce, splits in marriage, and either from the parents or the children can encourage us in later life, as I previously said about childhood trauma. So I think actually the benefits can be across physical and mental health. And I think that's really important to know, because it's not an homogenous group. There's several million people with individual needs. And trying to match that with one national service would be impossible. We do need those locally tailored services that understand the demography. Obviously, there's some issues with ethnicity and accessing services and the stigma of accessing services if you've had a marriage split. And so we need to ensure that we have access to all of these. So we need to target the resources appropriately for maximum impact in the cohorts that need them, while ensuring the statutory services are able to deliver their needs as well, because this isn't a crutch to prop up services. We need to ensure that the statutory service can have the interventions they want at the time they need them, by removing the people from those services who don't need to be there. And I say that in the nicest way, because there's a need at times for this. So sorry, not to answer the question, but actually to point out that it's actually a much wider point to try and answer.
Thank you. Would anybody else like to add to that? Jonathan?
Yeah, I think Chris is absolutely right. There's no one group, that one type of person, one type of presentation, any that would benefit from multi-agency working. But multi-agency working does really help. I think if we're going to try and answer the question, who's helped most, who benefits most, I would suggest it's those people that are willing to engage and recognise that trying something different is what's necessary. If we've had 20 years of contacting every single healthcare service and voluntary organisation to get their hands on, and it's not working, and that their root cause isn't being met, then what I've tried to say to some patients that I've spoken to is that if you've called us 50 times a month for the last 3 months and we still haven't helped, can we at least try something different? Because that doesn't mean that you're not it doesn't matter. It's just that we're not doing the right things. So it's about getting the patient to engage within their own care, and what that plan may look like with some support from various different angles.
Any response to that, or any further points?
Not saying it's easy to get them to all engage, because there's, like we said earlier, there's various different things that these people might have
endured during their lifetime, making it very difficult to engage. However, to answer the question who benefits most, I would suggest it's those people that choose to engage.
Yeah.
And I suppose it's building that trusting relationship between the healthcare provider and the patient, so to sort of encourage that engagement. And it does take time. I think what Penny said in her presentation was we can't put a fixed time to say we're going to manage the care for this patient over a 3-month period or a 1-year period or a 3-year period. You know, it should follow the patient's needs.
Thank you. Chris, you can have the last word.
Just one final thing to me, I think entirely right in what everybody's saying. What we also need to realise is it's not just a case of making those links to statutory services, sometimes repairing those links to statutory services that have been broken for exactly the point that was raised in Penny's presentation about it's that stigma sometimes that you've not attended appointments, you've had an argument with a consultant when you've turned up for a reason, you've had a really, really bad experience. Sometimes it's repairing those links with the statutory and non-statutory services that is really, really important. So to understand why there was a breakdown, why there was that issue, I think that's really important to understand that sometimes there's just little things that can be mended to re-engage with the site and re-engage with clinicians and re-engage with themselves to improve their outcomes.
Thank you. I'm now going to say thank you to you all and wrap up the session. I'm supposed to now do a summary of key points from that, and I'm a bit of a loss, really. I think the key points that I've picked up are that this is an issue which affects all emergency care providers and a lot of callers and attenders. There are a lot of people in this situation who are calling frequently and their needs are not being met. It's a very heterogeneous group. So although we know some characteristics, I think everybody here has made the point that every single person is an individual and has their own needs and their own circumstances and their own background, their own history. So I'm getting the message this is really important. We could do with more understanding of what works. And evidence about what works and how much it costs is really going to help us actually change practice and policy for the future. So I will thank you all again as panel members. We really appreciate the time and the effort you've put into this. I want to thank our technical support who are hiding there, Neil and Mark, and thank you to anybody that is watching this. Bye-bye, everybody.
Bye.
Thanks.